I'm Cameron Lewis,
I'm Emily Martin.
and we have the endocrine system. Here's our case study, our rewritten case study. Lydia, a 35-year-old elementary school teacher, started noticing unusual symptoms that disrupted her daily life. Despite sleeping well, she experienced asthenia and she had unintentional weight loss. She felt vertigo often and developed hyperpigmentation on her elbows and knuckles. She also experienced menstrual irregularities and occasional depressive symptoms. Concerned, Lydia saw her primary care doctor. She ordered blood tests after noticing her symptoms pointed to adrenal insufficiency. Results showed that her body wasn't producing adequate endocrine hormones, particularly cortisol and aldosterone. Lydia was diagnosed with primary adrenal insufficiency, aka Addison's disease, a condition where the adrenal glands located on top of the kidneys don't work properly.
Lydia had a history of Hashimoto's thyroiditis, another autoimmune condition, which made her more likely to develop Addison's. Additional symptoms included hypotension, hypoglycemia, hyponatremia, and hyperkalemia. She sometimes experienced orthostatic hypotension and had abdominal pain, nausea, and emesis. Lab work revealed electrolyte imbalance, dehydration, and signs of myasthenia. An ACTH stimulation test confirmed that her adrenal glands weren't responding as they should. She was also screened for other autoimmune disorders and tested for vitamin D deficiency, anemia, and thyroid hormone levels, which are often affected in people with Addison's.
To manage her condition, Lydia began daily glucocorticoid and mineralocorticoid replacement therapy to substitute the missing cortisol and aldosterone. Her doctors prescribed hydrocortisone and fludcortisone. She was taught how to give herself emergency corticosteroid injections during times of physical stress or illness to avoid a life-threatening situation called adrenal crisis. Lydia had to be especially careful during illnesses, pregnancies, or surgery. When hormone needs increased, her care plan also included regular visits with an endocrinologist, blood monitoring, and emergency action plan. She began wearing a medical identification device and kept a steroid emergency card in her wallet. Identification.
Adjusting to life with Addison's required physical, mental, and spiritual resilience. Lydia changed her dietary modifications to include more salt and fluids to maintain her blood pressure and prevent dehydration. She avoided physical overexertion and tracked fatigue levels closely. She added mindfulness meditation, respiratory techniques, and yoga to her daily routine. She also joined a local patient support network for people with autoimmune conditions and leaned into her spiritual beliefs for strength and peace.
In conclusion, Lydia's journey with Addison's disease shows that healing involves more than treating an endocrine disorder. It requires caring for the entire person. Through daily hormone replacement, electrolyte management, and emergency planning, she regained physical stability and prevented life-threatening adrenal crisis. Yet her progress was also shaped by mental and spiritual strength.
By practicing mindfulness, leaning on a supportive community, and relying on her spiritual beliefs, Lydia found peace, resilience, and hope. Her experience reminds us that true health is not only the balance of cortisol and aldosterone, but a balance of body, mind, and spirit. When medical care and faith work together, patients can live with chronic illness while still experiencing purpose, strength, and healing.